Now, the first part about acute leukemias is that acute leukemias are, although broken up into acute myelogenous leukemia and acute lymphocytic leukemia, acute leukemias are divided up into these. However, although most people who are adults get acute myelogenous leukemia and children get acute lymphocytic leukemia, some adults can have lymphocytic and some children can have acute myelogenous leukemia. Now, all forms of leukemia can present as if there is a pancytopenia. Now, pancytopenia is presenting like a person who has diminishment of all 3 cell lines with a pancytopenia. Now, pancytopenia in general is any primary cancer of the marrow, such as these, or metastatic disease, primary or metastatic disease to the bone marrow. Also can be infections invading the bone marrow, such as tuberculosis or fungus. TB or fungus go into your marrow and actually crowd out the other cells. The other thing is that you can have hepatitis B and C, which have an effect upon freezing the bone marrow with these viruses, hepatitis B and C, cytomegalovirus, and HIV, actually freezing the marrow so that the marrow does not grow. So you can have any cancer and infection invading the marrow. You can have effects of drugs, alcohol, and radiation, drug, alcohol, and radiation effect on the marrow, freezing the production of that marrow. Although you and I think of B12 and folate predominantly as red cell disorders, you could also have B12 and folate presenting with pancytopenia, all 3 cell lines down. Whites, reds, and platelets happens also with lupus. All 3 cell lines down with reds, whites, and lupus, and this happens, it hits all 3 cell lines as well as the spleen. Now, I know you're used to thinking of the spleen as a cause of platelet sequestration, which it is. However, the spleen can also cause the sequestration of all 3 cell lines. Now, what's different about all these forms of pancytopenia and aplastic anemia and acute leukemias? People are tired. Why? Because they are anemic and have a low hematocrit. People are bleeding. Why? Because they have low platelets and they complain of bleeding. Yes, they're bleeding. They have infection. Why? Because even though the white cell count might be high, because with acute leukemia, the white count can be high in 1/3, normal in 1/3, down in 1/3. Even though the white cell count can be high, the white cells do not function. The white cells do not function because they don't degranulate. You can have all the white cells you want in the world, but if they don't release the content of their granules, you might as well not have them. White cells that don't release their granules is like having a gun where the bullets don't fire. The white cells have to release the content of their granules to melt and kill the bacteria. So even though the white count might be high, they present with an infection most of the time. Bleeding and anemia, all of them, it presents like a pancytopenia. Now, what is different about these diseases that's different from all the others? You cannot get the diagnosis based on the history. You can't say, oh, well, you know, they had exposure to radiation. It must be acute leukemia. No. Well, I was born in Hiroshima in 1941. I moved briefly to Nagasaki. I went to the University of Chernobyl and I got my first job at Bhopal. You can't do this to say, well, they must have acute leukemia. What's different about leukemia from all the others is the presence of blasts. Blasts tells us we have acute leukemia, but doesn't tell us which type. We have to use monoclonal antibodies to tell us which type. Now, the same way that we have monoclonal antibodies against telling us whether we have hepatitis B or C, HIV or CMV or any of the other viruses, we have antibodies that tell us, do we have acute myelogenous, do we have acute lymphocytic? Which type of acute myelogenous? Which type of acute lymphocytic? Blasts. Now, there are also certain stains that can help distinguish them. Which of these has the stain positive for myeloperoxidase? Would it be the myelocytic leukemia or the lymphocytic leukemia with the myeloperoxidase? I think it's myelocytic leukemia that has the myeloperoxidase. The myeloperoxidase stain is positive because that's what happens. White cells, myelo. The same way they are the ones that also have the hour rods in them. Now there's also the common CALA, C-A-L-L-A, CALA. Which of these has CALA, the common ALL antigen, which is never defined in over 5 major textbooks? It says CALA, and you have to memorize it until somebody finally tells you it's the common ALL antigen. And that's why it's in ALL. Now, some of you may know that there are 8 separate types of acute leukemia, acute myelogenous leukemia. There's myelodysplastic, myelomonocytic, monocytic. There's 8 separate types, M0 to M7. And anybody who makes you learn the difference between the myeloblastic, undifferentiated, myeloblastic with differentiated, promyelocytic, myelomonocytic, monocytic, erythroleukemia, megakaryocytic leukemia, you should run away. Run away, run away. Because we're only learning from the point of view of how to answer that question, which of the following is the most likely diagnosis? And if they all have the same presentation, that means you don't need to learn it. It doesn't help. The only one that's different is M3 with DIC. M3, promyelocytic leukemia, presenting with DIC. M3, DIC. Disseminated intravascular coagulation. The only one you need to know different is the disseminated intravascular coagulation. M3, DIC. Why? Because you can't tell the difference between M6 and M7 by history and physical. You can't tell the difference between M1 and M2 by history and physical. So you can't answer the question, which of the following is the most likely diagnosis, off the history and the physical and individual labs. The other thing is that since they have the same therapy, you don't need to know the difference because they're all based on therapy with daunorubicin or idarubicin, daunorubicin or idarubicin, and aracine, also known as cytarabine or cytosine arabinoside. Aracine, cytosine arabinoside. So you don't need to know the difference because all of these are treated the same way, which is basically an alkylating agent like daunorubicin or idarubicin and cytosine arabinoside. So you don't need to know the difference because they're all treated the same way, except M3 gets added. You add all trans retinoic acid. All trans retinoic acid. The retinoic acid, like the stuff that you put on your acne, all trans retinoic acid is what's used for the person who has promyelocytic, because the retinoic acid, the vitamin A derivative, compels the differentiation of these immature cells and says, grow up, get a job. What's a promyelocyte? Or all blasts? They are immature cells. They're immature cells that they never grow up, they don't get a job, they don't go to work, they don't kill bacteria, they don't leave their mother's house in the bone marrow, And all they do is sit around in the bone marrow, never go to work, never kill bacteria. Their only job is to participate in unlimited reproduction, and they don't know when to die. That's a cancer cell. Cancer cell is a cell that does not know when to die. Doesn't work and doesn't die, just reproduces. But vitamin A derivatives compel differentiation. Grow up, get out of this house, turn that television off, get a job, finish school. The same stuff you use on your acne as retin A is the cis version. This is the trans version of retinoic acid. Now, ALL is also managed with a combination of daunorubicin, idarubicin, daunorubicin, vincristine, and this you don't have to know in order to pass. This is 90th percentile stuff. Prednisone, asparaginase. Now, you give the person chemotherapy and you knock them into remission. You give them chemotherapy and you remove enormous amounts of leukemic cells, and you finally get them down to where they're in remission. Remission means I can no longer see blasts on the blood, and I can no longer see blasts on the smear of the marrow. Now, even though you may not be able to see blasts, small ones can still be there because you're talking about a world with billions of inhabitants. How do you know there's not a couple of hundred in there? That'd be like space aliens coming down and landing in New York, and they don't see any blasts when they're on the street. Well, how do you know they're not in Kentucky? Do we have to edit out Kentucky? Okay, good. So the thing is, how do we know that they're not hiding out in Kentucky? Those blasts of those cells. Well, they don't. The space aliens land in New York. They say, well, I don't see any blasts, but they might still be here. They might come back. Well, if the cells come back, that's a remission. And if you have a remission, a relapse, it's a relapse. And if the leukemia relapses, you have to treat with a bone marrow transplantation. Bone marrow transplantation is what is done for everybody who has relapsed acute leukemia. Bone marrow transplantation. But the question is, who should we transplant as soon as they go into remission? Maybe we shouldn't wait for them to recur. Maybe we shouldn't wait for them to recur. Maybe we should eradicate with a bone marrow transplant after the first remission. We give them a round of chemotherapy, and that first round of chemotherapy removes 99.9% of all the leukemic cells with the first cycles of chemotherapy. 99% of the cancer? No, 99.9% of the cancer, and typically that's called remission induction. And we've removed all the blasts from the peripheral blood, and the peripheral blood looks clean. Now we wait before we kill you with the chemotherapy, and we give you some more chemotherapy again, and with more chemotherapy, you remove 99.9% of what is left in terms of leukemic cells. That's called consolidation therapy. Now, you go in again a few weeks later and give them some more chemotherapy and remove 99.9% of what is left? Wow, maintenance therapy, what's left? 99.9% of what is 99? Wow. And maybe you have eradicated the cancer. How do you know who should be transplanted right away or wait for relapse? Because waiting for relapse, if you try and transplant the relapse person, it's very hard to get them under control. Because if they relapsed, it means their cells are probably resistant to the chemo. It's like infectious disease. It's like microorganisms. I gave him an antibiotic. It grew around my antibiotic. Hey, it's resistant to the antibiotic. I gave him chemo. The cells grew around the chemo. Hey, it's resistant to chemo. What tells us? Transplant yes, transplant no. And the answer is cytogenetics. We know that certain genetic translocations are associated with a high degree of relapse. If you have a genetic translocation, that means, no, this person ain't going to relapse. then don't transplant them. Just give them more chemo. Oh, your cytogenetics mean you're going to relapse. You got a 40, 50, 60% chance of relapse. I wouldn't wait for the relapse, because once you relapse, your leukemia is out of control. It's very hard to control. I'd transplant you now before you relapsed. What I don't want to get transplanted. Bone marrow transplantation is no walk in the park. The mortality on an allogeneic transplant, the mortality on an allogeneic transplant is somewhat like 20%. And that's if you're matched and related. That's if you're matched and related. Matched and related? Related to the donor? You still have a 20%, 30% chance of dying. 1 out of 5 people? Whoa! Before I let myself get transplanted, you better tell me whether or not my cytogenetics are associated with at least a 20% chance of relapse. Because if I have a person who's associated with much less of a chance of relapse, then I'm not going to get transplanted, because if I have a smaller chance of relapse, I'm not going to take a 20% chance at death. Matched and unrelated is probably increasing closer to 30% chance of mortality. Whoa. Whoa. Oh no. I'll take my chances. Oh no, your cytogenetics show you got a 60% chance of relapse. Okay. I'll get transplanted now. Oh, terrible, terrible. Well, look at this thing here. Cytogenetics. Look, chemotherapy, inducing a remission. We remove 99.9% of the leukemic cells from the body. Wow, 1/10 of 1%. Only 1/10 of 1% will be left. Seems like a small number until you realize where we started out. We remove 99.9% of the cells, but maybe that leaves us with 100 million leukemic cells still. They're just not in the peripheral blood. Look at the population of the world, 6 billion. If you had 100 million of somebody, you could squeeze them all into one country and never see them in New York City. Well, consolidation therapy, removing 99.9% of that as well. Well, 100,000 people, heck, you could put them all in New York City in a 15-block radius and see 100,000 people. You could just go to the population and just get everybody that's between 34th Street and 42nd. You got more than 100,000 people between 34th Street and 42nd Street in New York City. It's easy to hide them. Well, maintenance therapy. Remove 99.9% of what's left. At this point, your own immune system may knock off the rest of those cells. And if it does, that's a sustained remission. What normal people call a cure, but oncologists never say cure. They don't say cure because they always want to say, but on the other hand, it could come back. So what you need is a one-armed oncologist, because your oncologist is always saying, but on the other hand. So therefore, if it goes away, you're cured. Sustained remission. It's kind of like boyfriends and I love you. Honey, I need to hear you say it. Oh, you know how I feel. No, I want you to say it. Sustained remission. Too much. Now, if it comes back, and that relapse, you got to do a bone marrow transplant. That's all you can do. But the question is, who should I transplant before those 100 cells come back to being 100 billion again? And it doesn't take that long. If you take 1 penny and you double that penny on January 1st, and you go from 1 cent, and you double it every day, by January 31st, you have $3.1 million. By January 31st, $3.1 million. If you take a penny and double it every day for a month. Therefore, if you take those couple hundred cells and double it every few weeks, you can easily get yourself millions and millions of cells, if not billions, within a few months, and you can't control it. So who gets transplanted in first relapse, in the first remission? Who gets transplanted in first remission? People who have cytogenetic markers that say, look, I know that that 20% chance of relapse and mortality is a disaster, but it's better than the 90% chance of death. Now, allogeneic means you take someone else's marrow and put it into yours. Autologous. Autologous means we take your own marrow and put it back into you. And it could be with stem cells or no stem cells. Autologous might be with or might be without using stem cells. Now, stem cells are the early progenitor cell in the bone marrow. The benefit of using stem cell transplants is that you're giving cells that are already grown up a little bit, and it grows back faster. The biggest problem with bone marrow transplantation is the duration of neutropenia. The longer you are neutropenic, 5 days, 10 days, 15 days, 20 days, 30 days, the longer you are neutropenic, the percentage with infection is directly proportional to the duration of the neutropenia. If you're neutropenic for a few days, you have very little infection. Once you're neutropenic for a few days, more than that, you start getting enormous amounts of infection. So the thing about autologous transplants is that there is no graft versus host disease. And there's no rejection, because it's highly unlikely you're going to reject yourself. The problem with autologous transplants is that there is also less of a cure, because you might be giving small amounts of leukemic cells back in. You're using monoclonal antibodies to try and cherry pick through the marrow to pull out the evil cells and put back the good ones into the body. Autologous, the duration of neutropenia is very short. Autologous, no graft versus host and no rejection. So the mortality from the procedure is much less, because the duration of neutropenia is very short. Allogeneic, somebody else's marrow into you. Matched and related, your bone marrow will come back at 15 to 20 days. Matched and unrelated, it'll come back a little bit later. Unmatched, unrelated, you're going to die of infection half the time before the bone marrow comes back to life. And then even if it does, you're going to have terrible graft versus host and rejection of that marrow. The duration of neutropenia is how you determine the mortality from the marrow. Who should be transplanted in first remission? The people with bad cytogenetics. What is unique about each of these? M3BIC, M3BIC, all trans-retinoic acid for people who have M3, promyelocytic leukemia. Okay, all trans-retinoic acid, a retinoic acid compound. Vitamin A, grow up, you marrow. What's unique? Intrathecal methotrexate. Acute lymphocytic leukemia recurs in the spinal cord. So we give intrathecal methotrexate, inject chemotherapy directly into your spine, into the spinal canal, to prevent the leukemia from coming back inside your own spinal canal. What's unique? We have a 39-year-old woman who's coming in with acute leukemia, who's got a white cell count of 240,000. Wow! She is having sludging in her brain and having confusion and signs of sludging in the brain. She's having shortness of breath from signs of sludging in that brain. She is having priapism, shortness of breath, visual disturbances. What would you do for the treatment? Yes, hydration. Now, in addition to hydration, what will you do for leukostasis reactions? These big, gummy white cells are clogging up your blood vessels because they're big and they get in the way. Like getting behind an 18-wheel tractor trailer or one of those SUVs stuck in the tunnel or on a bridge where you can't get around the thing. These big white cells get stuck and make it so that you can't perfuse your brain, your heart, your lungs. What is the therapy? Hydration, I know. And the therapy is Leukapheresis. Leukapheresis means that we're going to use a centrifuge to pull those blood cells out of the body the fastest possible way. Leukapheresis. Clear those things up before they kill you. The last type of transplant, what about a xenograft? What does xenograft mean? Xenografting means you're getting a transplant from outside your own species. And the answer is, you never date outside your own species, except one part of the body where you would use a transplant from another species. The heart. Heart valves. The only time that we transplant from outside our species is the pig valve. You put some pork, some bacon in the heart, and it is a person who gets a pig valve. Other than that, you either transplant cleaned up versions of yourself or someone who's matched and related preferably. Sounds like a dating service here. It is. Now, that's acute leukemias. That's based on who should be transplanted and why.